Okay, so this case is not from our hospital, but I found it incredibly interesting. This is why I wanted to share it. I think it's a rare case, but also it's very important for us to meet such cases because it makes you think out of the box. Now, I really appreciate it if we all kind of join in. There's no right and wrong. This is only these are cases for us to learn from and share our thoughts and see what we would do in such situations. So I'm going to start with a background. This is a 30 years old lady who's para 2. She had 2 vaginal deliveries, one in 2018 at 39 weeks, where she had ventouse, normally grown baby, but it was complicated with GBS, and also she had PIH and was on labetalol for the last week and a half. Her second delivery was in 2019, term, normally grown baby, and no hypertension. This pregnancy, she had uneventful care so far, and she had additional scan only because there was discrepancy between the fundal height and gestational age. However, the findings were of a normal growth lico and Doppler. She presented to triage at 39 weeks and 2 days with queerish ROM and reduced fetal movements. At the time, they've done amniosure test, which is equivalent to the ROM plus we have at Croydon, and it was negative. When they examined her, she was 1 centimeter dilated, 2 centimeters long. However, they've noted that the blood pressure was high on admission. The first reading was 150 over 90 diastolic. However, when they repeated it, it was 135 over 80. Luckily, they've done PET bloods, but they were normal. And also they've noted that the heart rate assessment on that review was 114 to 122. So they've done an ECG and it was a sinus tachy. Now I'm going to show you the initial trace from that encounter, and this was it. I do apologize if the quality is not very good, but it's kind of like I had a couple of screenshots several times. So at this encounter, I just want anyone to shout out what you think. So this is antenatal CTG, produced fetal movement, and queerish from which we ruled out, and this is what you meet the baby in. So anyone? What you're thinking?
CTG. Yeah. Normal.
Normal. Okay, so the baseline rate is 150. Is it suitable for the baby's gestation? Yes,
no,
but it's a little bit
tacky.
A little tacky.
And there's a reduced variability.
Reduced variability. So what they've done at cycling. They've done here, what they've done is that they put her on the right lateral and the variability improved. So they decided they reassured the lady and discharged her home. However, they made a plan to follow her up next day in view of the maternal tachycardia and the high blood pressure, just to do a day assessment review. So she came in next day, and this is what you see. This is the start of the CTG. So initial admission bloods, her heart rate is not blood, sorry, observations. Her heart rate is 180. Now her blood pressure is 171 over 100. She's got temperature of 38.4 and she's contracting 5 and 10. And this is what you see. So I want us now to think. We know what the background is, and this is what we received. This is the starting CTG. We know the baseline was 150 from yesterday, but this is what we have. What's the first thing that comes to our mind, and what are we thinking, and what management are we starting to think of?
Any just protein quickly, in the U?
Yeah, did they treat the blood pressure yesterday with anything? Any
nothing. So they've done a second blood pressure. It was 130. They called it normal, and they said, let's assess the second day, considering she's asymptomatic for PT. She was just feeling unwell. She came in with reduced movement, feeling a little bit unwell, and had queerish ROM. They've done PT bloods. They've checked it a second time, and they've sent her home.
And no protein.
And no protein.
Did they send a PCR anyway?
No.
Looks like an abruption.
Okay, any other thoughts? And what's your plan? Her blood pressure now is 171/100. She's tachycardic and her temperature is 38.4. She's distressed. So they've started initial assessment, initial management, ABC type of thing. And then if you notice at the end, the baseline suddenly started creeping up to 1 to 200. And then they called the SPR for reassessment regarding emergency section. Do you agree? What would you have done?
The blood pressure. Need to stabilise mum first, I think. Escalate, but stabilise mum with blood pressure. See what's happening there. Is she any signs of sepsis? Just.
Well, so far we've got high pulse and high temperature.
How many centimeters is she?
So they've not examined her yet. This is hopefully going to come later, but this is literally within the 20 minutes. They've admitted her to labour ward. They've managed to put an IV line. Within 10 minutes, they've sent some bloods and septic screen. As you can see from the arrow, sorry, this one a little bit on the side is out of where I wanted to be. So this is when they admitted her, put her on CTG, done her observations, and this is what they have. So if it was you, what would you have done? What are you thinking? What's your plan? You've admitted her, you've given her IV line, done your screen. What would you do? What's your next move? What are you thinking?
I think VE would be.
Okay, very good. What are you thinking? What are you trying to exclude?
The first of all, is she in pain? Is she like any
Well,
sign
she
of,
is contracting 5 and 10, so yes, she is distressed.
any other signs of placental abruption?
Well, so far she's got membranes intact. We've not examined her. Yesterday we ruled out SHROM. At the moment, we only have the high blood pressure and the signs that we probably have high temperature and high pulse. So they were thinking probably of sepsis, but at the same time, they were thinking of high blood pressure. Anyone wants to contribute? Any help? Come on, you're the registrar on call at night. What are you thinking? So they thought, are we thinking of PET? Are we thinking of PIH? Are we thinking of sepsis or uncontrolled pain? So the blood pressure was high. So they decided their plan is that they're going to measure the blood pressure every 15 minutes, put a line, PET bloods, catheter for urine dip, and luckily PCR as you requested, Natasha. And they're going to give her pain relief, hopefully anesthetic input. And they're going to consider antihypertensives and magnesium sulfate and VE. Now, would you deliver?
No, mum's not stable.
Would you? Exactly. So she's not stable. So the first thing that you might think, they call the SPR, let's take her to theatre, let's do emergency section under GA. But what happens when you have a very high blood pressure and you've not stabilized is that at induction of the anesthetics, you can have a blood pressure spike. And this actually can really lead to complications. So you would never take this woman straight to theatre before stabilizing. Okay, did I go back? I did. Okay. So now the tachycardia, what the causes that are we thinking? The maternal tachycardia. Initially yesterday, we've seen her, she was 120, now she's 150. It could be infection, she could be in pain, it could be arrhythmia, but we've done ECG and it was sinus. We could be thinking of PE, but she's not symptomatic. Hypovolemia, abruption, as someone just mentioned, could be inflammatory. The plan for that would be review her regularly, ECG, oximeter, probably ABG to check her lactate. You could also think of beta blockers, labetalol, metoprolol, or propranolol. As for the pyrexia, so you're trying now to get hints from everywhere. You're thinking of infection, sepsis, could be inflammatory state. So you're planning to check the temperature. This is what they've done. They've done the VBG. And also they've done COVID because this case was done COVID swab. This has done during COVID pandemic. So could this be a COVID cytokine storm? They're thinking of all the possibility. They've given IV paracetamol and started her on antibiotic. And you could also think of high vaginal swab, all of the septic screen and the input-output. This is our standard bread and butter, hopefully. However, the fetal heart rate also is rapidly rising. You've seen that slide where it was creeping up from 160 to 200 in literally 15 minutes. So what could it be? Along with uterine irritability, you can think of suddenly rising maternal temperature, choreo, abruption, cytokine storm. Their plan was to give terbutaline. However, we discussed last time, I'm not sure if many of you were there, that you need to rule out abruption before you give terbutaline. Otherwise, you will relax the uterus and expand the abruption space. Now, next, this is the CTG. I want suggestions. I want to know what you guys would be doing. Don't look at what they've done. What would you be doing? What are you thinking?
I'd be preparing to deliver this baby and stabilizing mum as soon as possible.
Okay, but did you stabilize? What are you thinking?
How the uterus? Have we done a scan? Have we seen what the uterus is doing? It looks like she is contracting, but actually, is it soft? Is it relaxing? Is there good resting tone? We're giving terbutaline, but actually doesn't seem to be working, which makes me think, why is it not working?
So are you thinking of abruption?
Yeah, I'm thinking abruption with choreo, because you've got such an irritable uterus and the fetus is responding in that way. You've also got maternal tachycardia, so yeah, it doesn't
fit the picture.
No.
Anyone else?
So I think that's a pathological CTG that
it is pathological. I agree.
We sat on it for so long. We did our emergency or tried to manage it. We gave terbutaline, we gave IV fluids, we gave everything, and it's still pathological. So I think we need to deliver that baby.
Okay, so, but what are we thinking? Because obviously now all of those things that we normally treat individually, this CTG is telling us probably they're happening at the same time. So you're thinking, I'm having abruption, I'm having choreo, I'm having PET, I'm having COVID cytokine storm. So what are we thinking? Mr. Naguib, help. What would you do? Because here at 1640, we call the consultant and we're not sure what to do. They've started IV Ben and Pen, and they've given a second terbutaline, IV paracetamol, IV antibiotic, and they've given her analgesia. They gave her pethidine, and they inserted a catheter, and they've done an MSU and a urine dip.
How's the blood pressure?
Yeah, what's mum's vital signs?
Yeah, so we come here. This is the next slide. If you look down, you can see now the maternal blood pressure is 145/98, but her maternal heart rate is 190. Can we all see it at the beginning of the slide? Her temperature creeps up to 39.1. Can you see it in the red circle?
Maya, what's the lactate for this lady, may I ask?
They've not done the lactate. We don't have results yet.
Please, can we deliver the baby?
Okay. Apart from that, what are you thinking? Yes, we all want to deliver this baby. Neil, what are you thinking?
This woman's incredibly sick.
Looks like it looks, for me, it looks like choreo, Maya. Like maybe due to some other cause. Like I don't know why it's choreo. Like it might be COVID related placentitis or something like that, but it looks like a choreo trace to me, Maya. And at this point, if I see that with a high baseline, the variability is slowly disappearing. Yeah, definitely I would think of delivering this baby.
Are you thinking of superimposed hypoxic stress?
No, not really, because I didn't see any decelerations at any point. What I saw was a high baseline, but now since the variability, now since the variability is reduced, I'm just thinking, like, is this a sign that now the brain stem of the baby is even getting affected?
Okay.
But mum's not stable yet. I wouldn't be keen on transferring her to theatre to deliver this baby when we still haven't really. The blood pressure's come down, yes, but that tachycardia on mum is very worrying. Yeah, so I'd be more worried about mum right now than the CTG. I know baby's not coping, but actually mum is very, very poorly, and that is my priority. So I'd want to focus on that.
I think so. I think Sosha, if in theater they can stabilize the mother, and also they can stabilize the tachycardia, and delivering the baby would stabilize the tachycardia at that point.
In what way? Because you're thinking of choreo. Is that what you're thinking? If we deliver, then we're stabilizing.
I think
this is
of
sepsis.
anything, like one of the steps for resuscitation of pregnant woman from the ABC is delivery of the baby, and that would reduce the blood flow taken to the baby and return to the mother, and I think it would stabilize the mother itself.
So we're all thinking infection here? Are we all thinking that?
Can I just ask?
Yeah.
Obviously, the terbutaline that we've given, when was it given? At 4:30? In the previous slide. So we've given it within the space of, and it's the initial time space of working is 20 minutes, but clearly that's not happened. But we also know that can increase the maternal heart rate even more so.
Exactly. So
why are we giving another one? This is a genuine question. Why are we giving another one when her maternal heart rate is already high and increasing, and we've clearly seen that terbutaline is not stopped at the first place? Is there? I want to know what
what they were thinking.
Yeah, and also if there's any statistics as to if the first terbutaline hasn't worked, is the second one more likely to work than the first? Like that kind of thing. That's the sort of thing I don't know enough about.
I think, Kara, from the point where the second terbutaline came, is that if we go back in the trace, I think from the first point, even I was not sure whether there's a hypoxic trace or it's a choreo. So if you see, there are uterine irritabilities present all through the trace.
Oh,
so
sorry.
what they were,
how do I go back?
Yeah, that's fine. Yeah.
Press your arrows, Maya.
Yeah.
I know. Sorry.
Yeah. So what they were trying to do is a kind of a hit and trial over here.
Like I think exactly. I agree. It's a hit and try. Try everything.
Yeah. So they gave the first terbutaline, but the uterus didn't become cool. So they tried the second terbutaline. What they wanted to do is that make this toco part totally flat and see how it affects the cardio part. So in that case, if the toco becomes flat and the cardio comes back to normal, in that case, they can somehow retrospectively prove that this is a result of hypoxia rather than choreo. I think they were trying that only.
Okay. I just want to know, like, does anybody actually have the statistics or any like percentages of, like, in a normal circumstance, if we're not seeing the benefits of, obviously this is quite an extreme circumstance, but if the benefits of terbutaline aren't seen after the first one, what is the likelihood of it happening the second time?
This is genuine hyperstimulation, and you might consider, but in this case, as Neil said, I think it was literally they were trying to hit and miss, trying to use everything they have, and trying, as you can see from the end, they were awaiting the effect of terbutaline, fluid, paracetamol. So they were trying to kind of like just relax and stabilize and wishing for the best.
Yeah, so I want to say a few comments, please. Number one, about the terbutaline, if you are giving the second one in a very short succession, I think you should be thinking about delivery usually, because whatever you are doing is not relaxing and you are very worried about the hypoxia. So this is general. There is nothing 100%. The second thing is about giving terbutaline with the suspicion of abruption, and we discussed it last time, as Maya said. So, and again, we need to differentiate an important point. Anytime the uterus is contracting, you cannot 100% exclude abruption. So unless you are very sure that there is abruption, you don't give terbutaline. If you are not sure it is abruption, you can give terbutaline. Terbutaline is, you can give it when you are thinking it is hyperstimulation. So this is very important. We cannot say generalized rules of we can never, or we can't 100%. In what I do in my practice usually is everything has a 1%, a 5%, a 10%. We cannot say never. So when you are thinking abruption, yes, and you don't have overt abruption, you don't have bleeding in front of you, this is when you can't give. Yes, this is the 100%. The third thing about how I am thinking about this case is, as Maya said, we are in the COVID time. I am thinking more of not only of choreo, and it is also of a generalized sepsis from possibly the COVID that could have done a COVID placentitis itself and could have done small micro thrombi in the placenta that is causing the placenta to fail. So it is a combination of the COVID, combination of the sepsis, and of the choreo. So it is two at the same time. You cannot also always know what is the reason for what the baby is doing unless delivery. So I agree with all of you that delivery should have happened maybe once we stabilized blood pressure with magnesium sulfate, we go to theater for delivery. It will alleviate the compression on this uterus and on the aorta, and then give more supply to the woman to become better. It will get the baby out of this environment of sepsis. So yeah, this is how I think about it.
And probably be alerting our critical care colleagues as we decide to deliver.
Definitely, and think about the chest of the lady, because yes, now we have given twice the terbutaline, and it has made her blood pressure very high, and maybe she has also chest that is not working very well. I'm not sure about her chest symptoms as well. Yeah.
Thank you so much, Mr. Naguib. So here in this slide, they actually continued on the thought that this is sepsis, and they started giving her a second bag of Hartmann. Guess they're thinking PET, but they're still pumping her with fluids. They've given IV gentamicin. At 1801, she's more comfortable and the contractions are spacing. So probably the second terbutaline and the first one are now kicking in. She's more comfortable and they are spacing. Her blood pressure at the beginning of the trace is 149/93. However, her heart rate continues to be 172. Her temperature was 37.5, so the effect of paracetamol fluids probably for cooling are showing on the mom. The CTG, however, we can see that the baseline is still high, going slightly dropping from 200 to 180, but the variability continues to be incredibly concerning. So all of us now literally are sitting in our chairs, waiting and seeing. Probably, yes, I agree. I would have definitely maybe delivered at this stage, but when we look here, this is not what happened. It continues.
You know, Maya, why they are not delivering, or why do we all fall in this? You know, because she had two normal deliveries.
Exactly.
2018 and 2019. So everybody is thinking she will progress from 2 to fully in the next 5 minutes.
Okay, that's exactly. So we all feel incredibly sorry if we section a para 2. However, we always have to think that what are you trying to achieve, and what's the outcome you're trying to achieve? Are you trying to give the mom a healthy baby, or you're really dreading the fact that somebody's going to look at you and say you've sectioned a para 2? We have another consultant review at 1820, and luckily at that time we have the results from the bloods that we've taken. So the HB is 124, white cell count is 17.8, CRP is 3, a normal liver function test and use an ease. Urine showed trace protein and trace of ketone. So what are you thinking?
And what about the lactate, as Neo asked?
All normal.
Just a question. The first consultant review, what was the plan from their point of view? And did they say that why they were waiting for or anything?
So the first one, they said that they're going to give IV antibiotics, they're going to give paracetamol, fluids, analgesia, catheter, monitor closely, and conservative management, and they've given her pethidine.
And then the second one, they will...
And the second review, they've given some more, they can gentamicin, and they reviewed the blood results. So what are you thinking now? You've got a CRP of 3, you've got normal PET bloods, the urine is really not that impressive. So what are you thinking now?
And that's 30 minutes after the...
You've given terbutaline, IV fluids, paracetamol, antibiotics, but now the bloods are telling you this is not PET and normal inflammatory markers. So what are you thinking?
Could this be some sort of crisis? Some sort of, like, I don't know, Addisonian, or like if the fever's really odd, or some sort of, I don't know, malignant, I don't know, like hypothermia, but she hasn't had an anaesthetic. The high temperature's really like,
so
throwing it.
Also, you would think of reviewing her medication if she's taken anything.
Maya?
But you can,
Sorry. Any cardiac history from her?
No cardiac history. Absolutely no cardiac history.
And no autoimmune, no nothing.
Nothing. Just her PIH first pregnancy, and she's GBS positive. So this is why I keep putting for you on the right side here the background, so that we can keep on revising what her risks.
She had GBS sepsis.
She had GBS in her first pregnancy.
Yeah, could be GBS sepsis, as in like full-blown sepsis.
So, choreo, you're thinking again?
Yeah, well, choreo, yeah, but secondary to GBS rather than our,
But CRP is normal, Jane, and the lactate
could be a lag in the CRP. Her white cells are 17, which is not sky high, but it's still raised.
Okay.
Is she a drug user or?
No.
No recent travel?
No recent travel.
Okay.
So what they've done? Sorry. No, they haven't. No, they did not scan at that stage.
Okay.
The plan was to monitor closely.
Thyroid status normal.
Say again?
The thyroid status, is she euthyroid?
They've not checked it yet. So they've only sent PET bloods. They've sent just the infection screening, and they've planned to VE her at 2040.
And the
so
ECG
in 2
was
hours.
sinus tachy.
Pardon?
Sorry, what's that
ECG was sinus tachy.
It's sinus tachy on the CTG. On the ECG.
What's her COVID status?
So far, did we have it back? I don't think we've had it back. Because they were thinking of cytokine thyroid storm. So it's good that you're thinking.
Because the other day I had a patient who was lateral flow negative, but the PCR come back as positive.
Okay. So it could be as well. So we do SBAR. Do you guys do SBAR frequently? Are you acquainted with it? The situation background assessment. So exactly what we've mentioned, her situation, her background, just keep on checking the risks. Could I have missed anything? Is there anything else that could have happened? She started with a blood pressure of 170/100. With temperature 39.1. So it's not a low grade temperature. It was a very high temperature. However, we look back, the bloods are normal. She's very tachycardic, increased from 160 to 180 after terbutaline, and now settling at 150. She came in with contraction, 5 and 10. She had 2 terbutaline and pethidine and improved. Baseline of the baby started 145 and went up to 200 with terbutaline and fever. However, now it's hovering around 180 with reduced variability. The last VE was 2 centimeter and it was effaced at -2. So they were thinking choreo, maternal infection, considering the temperature. However, they were dazzled with the fact that her CRP was low. So what could cause the fever and tachycardia and high blood pressure, and what is your plan? And we've mentioned so many people contributed to that.
Maya?
Yes, my darling.
Can I just ask a question? Would anybody else have actually given pethidine in this case?
No.
She was so distressed, and because they were thinking of infection, the anesthetist thought it's not safe to give epidural during severe infection. So they thought with her distress, pethidine is the safest thing.
And we don't have a COVID swab back
Yeah, when you have severe infection, the anesthetists normally they are a little bit reluctant to giving epidurals. So that was the only other available option they had. Now next, we're progressing. They're sitting on hand. We notice here that the maternal pulse, which is in green, is pretty much getting close and close to the fetal heart rate. And I think this is a scary moment for all of us when we see them getting so close, because you can't know which is which. So her maternal heart rate is 160. Blood pressure now is much better, 154/87. We keep on progressing. 19, they hand over slightly earlier than we do. They give her a third bag of Hartmann. And then the midwife at 1940 asks the registrar to come and do ultrasound scan, finally, hallelujah, to see the fetal heart rate, as it's very similar to the maternal pulse. You can notice here that the contractions are less regular, more spaced. However, they want to make sure that we are monitoring the baby. So the next, the COVID comes negative, and it's not a lateral flow, it's the actually rapid test. They have the 2 hours VE, and they notice that it is LOT. Oh my God, I did not put the dilatation. Let me check it on my other one. It's okay, I'll find it in another slide, but she progressed. I think she's 3 centimeter, COVID negative. The consultant now declares this is viral infection. However, it's not COVID, because they digged from the history that her 2-year-old has got DNV. So this is severe viral infection. The blood pressure is now settling at 29/89. The fetal heart and the maternal heart rate is at 156. Sorry, this is the one I was looking for. So VE was 3 centimeter, presenting part -1, and they do ARM. Now she's contracting very well here, and both mom and baby are not happy. Would you have ARM at this stage?
No.
Okay, she's contracting. I can
think
see.
maybe they're thinking of
1, 2,
FSC
3, 4, 5.
I would have delivered that baby a long time ago. Not ARM, no nothing.
But now we're here. Would you have ARM, and why not?
If the uterus is very irritable with, I can see that 1, 2, 3.
Yeah, she's contracting
4.
5 and 10.
I wouldn't ARM.
Okay. Anyone else?
You've got one reassuring sign though, that this baby is still reactive to the VE.
Exactly. So that is actually very good. When they VE'd her during those 4 minutes, the baby was reactive. So that was actually a very reassuring sign. Thank you. And they've done ARM, and it was blood-stained glycol. Next, the ward round, and they say that's the night ward round. They say let's VE in 2 hours after ARM and give IV antibiotic and put an FSC now. And please escalate if any concern. I don't even know what that means. I mean, I've been concerned about this mom and baby since the second they stepped into the unit, and then they say escalate of concern. But anyway, I appreciate that. Now we can't tell who's who, so they decided to put an FSC. They put an FSC and she progressed. She progressed to 4 centimeter. So I put here a small slide with what we've done so far so that we can keep on remembering what's going on. The mom continues to be tachycardic. We have a slight blood pressure rise again, but at least now we know that we're monitoring the baby. What do we think here? She's asking for epidural, but again, high risk of sepsis. The anesthetic doctor is not going to give it to her. So she decides that she's going to continue without epidural, but she's having some urges, and they examine her and they found that she's 8 centimeters spines and it's OT. Now from here, are we happier?
How many minutes was this reduced variability, Maya?
So when I'm looking at it now, it's cycling actually, Neil. So we can see here that we actually started to see some positive signs. The baby had 20 minutes And now we can see that it's cycling. However, the maternal pulse now is starting to get higher than the fetal pulse. Can you all see that? Can you see the green line? The green line is mum. The black line is baby. So now the mum is more tachycardic than the baby. But she's progressing. So she moved to 8 centimeter. Are you happy to continue? Anyone?
No, because the mum's still quite unstable. If she's that tachycardic, would you really want to carry on through labour and then potentially push the baby out and put even more stress on her heart, you know?
So would you, if they're not happy to put epidural, I don't know if they would be happy to put spinal, but what do you do? General GA section?
Maya, if now the baby has started to become reactive, and if the CTG, the baseline is normal to gestation, without any hypoxic stress, now it's a tough call to deliver this baby by C-section at this moment.
Well done. But what about mom? She's incredibly tachycardic now.
The only reason to deliver is that if like we can establish that the mom is in sepsis or there is some acute ongoing crisis going on with the mom, for that reason we need to deliver the baby. Because if I'm looking at the CTG as a snapshot from now, it's quite hard to make that call, because if anything goes wrong in the CS.
And I gave you an answer now. So 10 minutes later, she starts active pushing. They veer her, she fully dilated, and she delivers the baby at 22:47. Now, I want us all to play the game that we play every CTG meeting, is guess the result. Just shout out. I don't even know who's who. Just say, what do you think? PH, Apgar, and then we'll find out what's going on.
She delivered within 6 minutes of this deceleration.
Okay, so now we do have some added hypoxic stress. We agree?
Yes, definitely.
Okay. Okay.
But
so it was a quick delivery.
Quick delivery. I'll still call it around 7.10 to 7.20. Yeah.
Okay. Anyone else?
7.1, and the Apgars would be 8, 9, and 9.
Okay. Anyone else? Okay,
How long ago was the pethidine for this baby?
It was more than 2 hours ago.
Okay.
Okay. I'm going to reveal the result. And Apgar, we don't have a 5-minute Apgar. We've got 5 at 1 and 9 at 10. The arterial pH is actually 7.0 and the venous 7.26 with a base excess of -8. So we do have a little bit of acute element, but the baby all in all did very well. Now, can we all put our money on what happened? I just shout out what you thought was that case. With one word.
Sepsis with an acute cytokine storm, which later on stabilized and then carried on.
Okay, anyone else?
Any blood clots after the delivery, or?
We've just done the bloods. Remember? They didn't see indication of repeating them.
No, I mean blood clots as in after the delivery. Like
no blood clots. No absorption.
I would say sepsis also.
Okay. Natasha, Candice.
I mean, there was definitely sepsis there, but it didn't behave in an entirely
sepsis
way, and it seems like there was something else going on alongside it, whether that's something fetal, an element of an abruption which wasn't catastrophic, that pushed her pulse up, but the baby is great. So I mean, we'd have all sectioned that baby hours ago.
I'm very glad as well. Actually, only one of you mentioned something which, if we digged more into it, could have been right. And that person is Neil. blood, they've done blood, they've done TSH and 3T4, and they diagnosed Graves' disease. And this case was a thyrotoxicosis. It's a storm. It's a thyroid storm. So initially, when I've seen this case, I also thought what Natasha has been kind of trying to follow, like, is this like a pheochromocytoma? Because you can really, if you've got an adrenal problem, you can push all of the those lovely adrenal juices, and then you can have tachycardia and high blood pressure. However, what dazzled me is that you don't have high temperature. You don't have 39.1 with that. However, when I looked at literature, there's only 2 case reports of thyroid storm in pregnancy and during delivery. And they all say that they have tachycardia, high blood pressure, reduced variability, and there's another one here. And this is actually thyroid storm case. And this is why I wanted to discuss it, because we always, need to think out of the box of the things that we do not encounter on a daily basis, because I believe now we are really good with managing sepsis. We're really good with managing the most common things like PET, choreo, all of this that we encounter on day to day. But this case is actually of a thyroid storm, which is a life-threatening condition, and it's hypermetabolic state induced by excessive release of thyroid hormone. It could be the initial presentation of hyperthyroidism, but mainly this is in children and neonates, and it can present as fever, tachycardia, hypertension, neurological and GI abnormalities, and it could be fatal if left untreated. It's very small incidence. You could encounter 2 to 4 cases per 1,000. So we might have a chance actually to encounter things like this. And things that can induce it could be PET, induction of labor, surgery, infection, sepsis, and even pregnancy itself. The etiology is Graves' disease, could be toxic goiter, rare tumors, including thyroid carcinoma, HCG secreting tumors like hydatidiform mole, and sometimes medication. Treatment in a nutshell, because this is a CTG case, I'm not going to actually go through the treatment. However, think of it when you're, Neil thought about it actually. He mentioned, did we check the thyroid when he saw tachycardia and high blood pressure? Work as MDT, ask a friend, and always do not forget the ABC approach. You do not want to take someone who's unstable to theatre because you might aggravate things. Decrease the thyroid secretion and block its effects peripherally. So you can here actually use beta blockers like propranolol. You can give 10 to 40 milligrams 6 hourly, or metoprolol for the palpitations. And consult a friend from the medical side or endocrinologist during normal hours. Ask them what we can give. In this case, they gave PTU, iodine, and hydrocortisone. In cases of prematurity, DEXA is preferred. So this is exactly what they gave, and we had good outcome for both mom and baby. And that's it.
Can I ask a question, Mo?
Yes, indeed.
Would sectioning her and putting her under operative stress at the point that most of us wanted to, would that have worsened a thyroid storm? Would that have caused additional stress and additional kind of needs, or?
In this case, I think she was already in the middle of the thyroid crisis, but part of stabilizing her, I think we could have given her, if it was diagnosed at slightly earlier stage, you could give her a big, the management from the beta blockers, the propranolol. Obviously, she had beta blocker for the assumption of PET, but I don't think it was in the dosage of as a thyroid toxicosis. But I don't know the answer to that. I'm not maternal medicine specialist. I don't know if Mr. Naguib can help me, but it's not something that we encounter on day-to-day basis to kind of have an answer for that. As I said, the only 2 case reports I found were the ones I'm happy to share later in a link, but to be honest, I don't know the answer to that.
And my other comment is just that's incredibly brave obstetrics not to have delivered her. Early, and that's incredibly brave obstetrics not to have delivered her early, and credit to them.
Yeah, the answer to that, Natasha, is I don't think it would have put any risk to the mother, because imagine the actual, what is the actual stress really from delivering it? You would reduce the stress. So if you take for example, the people on steroid, and you give them hydrocortisone to manage the stress of labor, you stop after delivery. So the actual stress would go with the labor finishing. So it would alleviate the stress actually.
And would the GA at that point would have made a lot, made the crisis worse? That's another question.
I think yes, it is another stress factor that would have added, but to be fairly honest, you have to balance. At that point, they weren't thinking of that, but if you know this is a thyroid storm, then obviously you want to resuscitate the mother, and delivery of the baby is part of that. And then you can actually administer everything at the same time to ensure that. But I think also I don't have a definitive answer to your question, Ahmad. Would yes, it is a stress factor, but would it have caused harm? That I wouldn't know.
Yeah, I have as my mother was anesthetist, the putting under general anesthesia would have exacerbated the stress, and some people don't even wake up from the thyrotoxic crisis after GA. So I think after the CRP came as 3, as Maya said, the anesthetist would be possibly leaning towards a shot of spinal.
Yes, so, spinal, yeah, exactly. Yeah, but not GA.
Yeah.
This was a close call, Maya, because sometimes in untreated Graves' disease, thyroid storm, the mortality can be as high as 75%.
Yeah.
Yes, definitely. Yeah.
But honestly, the obstetric team was very brave. I have to say that they were very, very brave, and I think the input from the medreg or the medical team would have been very beneficial at that point when she was.
But they weren't thinking of kind of like medicine. They were initially thinking this is something we can normally manage on day to day. This is choreo, this is sepsis, or this is preeclampsia.
That's why when all the bloods came back normal, all the CRP came normal, and everything came normal, they must think at that point to consult with the medical team at that point. I think that would have been, if they were sitting on her, they didn't want to deliver her at that point. I think that would be in a plan. Don't you agree?
And I think, yes, they made that conscious decision that they're not going to deliver. I mean, initially she wasn't progressing that quick. In my view, she only progressed literally at the very end. So I see what you mean by they were very brave. One time, consultant called Susanna Pereira told me, and I always remember it, that sometimes by doing nothing, you're actually doing something. In this case, I wouldn't even dare to do nothing. I would also be jumping on this patient thinking what's the safest way to deliver her ASAP. And I wouldn't personally have sat on it for such a long time. And as you put it, they were very brave in doing that. But sometimes by doing nothing, you're actually doing something. So you can't say I'm not doing nothing. I'm monitoring and I'm assessing and I'm reassessing. This is why it's very important for us also to look at the SBAR type of things, where you look at the situation, what you've managed, and always try to think in an MDT. Could someone, like now we were discussing, all of us here, one person could have said, you know, I've seen this, I've heard of this, this could be that, let's do that, and then the puzzle would unreveal itself. So I think always don't feel embarrassed of asking friends, of getting more opinions, because sometimes that could be the clue of how you're managing this case, especially the ones that, you know, it doesn't fit in our bread and butter, in the things that we manage every day. But yes, I wouldn't have predicted it, and I don't know. But it's interesting to kind of see things that we don't normally do. So this is why I thought I would share it with you, because I thought it's incredibly exciting.
Sorry,
Maya.
Oh, carry on.
No, carry on.
Sorry.
My only other thought in it, sorry, is just what immediately struck me was how long a baby's brain is being cooked for as well. Like those temperatures were 39, and so regardless of cause, my other thinking about delivering was, I mean, that baby's under, you know, severe pyrexic stress. What are we doing to this baby's white matter? How long was it under those temperatures?
It's very true. Now, I think looking back at the trace, the mom did have almost 2 to 3 hours of pyrexia, and this is why they were pumping the fluids as cooling, which I thought is incredibly brave if you're worried about the blood pressure and preeclampsia. And they give IV paracetamol, and she responded well to that. But yes, if we had infection with superimposed hypoxic stress, we're just cooking the baby's brain. We're just making it like a boiled egg. Absolutely.
And what I want to say from maybe sharing my experience with you guys, from my point of view, it is not only brave, and although the case is fantastic and I love it so much, I think in day-to-day management, this is just a side thought, the one who is going to assess all of us in the coroner's inquest and in any case that goes to the GMC is a colleague obstetrician. And the colleague obstetrician, unfortunately, sometimes is 14 to 20 years out of practice, who hasn't practiced obstetrics for a long time. And for them, they still follow pathological and this kind of things. And for them, if this baby came by any small chance of any damage to the brain or even dead, the problem is all of us will say, oh, we knew that this baby would have done this, because we managed all cases, unfortunately, in labor ward in prospect, not retrospect. So it is difficult to manage the case in the same way in the current day and age. Maybe yes, maybe maybe some time ago, possibly, but yeah, I don't know.
Okay. Anyone wants to comment or ask? Or
can I ask a quick question, Maya?
Yeah, please do.
Had we identified the Graves' disease antenatally, what would the plan be?
She's never had anything. And
no, but if we did know, so so just as like a general consensus, if we've got women that come onto the unit and we pick up in antenatal care, or we know through their own medical history that they've got Graves' disease, what's the sort of plan of care when it comes to labour? Do we induce early, or?
They normally go under the care. If the unit has got maternal medicine consultant or endocrinologist, they should be involved in planning the delivery. But also it depends on how well it's controlled and what sort of symptoms the woman has. But we don't normally screen. It's not like diabetes. You've got risk factors and then you screen the woman towards diabetes. It's a medical condition, and it's also very rare to have kind of such presentation, like she's starting really at the extreme end of the thyroid disease, probably induced by pregnancy and labor itself. But normally it's a multidisciplinary. In some trusts I've seen, they normally go under the endocrinology clinic with combined obstetric care. So it's kind of a joint clinic. I don't know, Mr. Naguib, here, how do we manage those cases? Who looks after them?
We refer them to the endocrinology clinic, say, and they have a review by the endocrine team, and they come to us in the antenatal clinic normally.
With a plan. Yeah.
I think, Maya, the point which we would like to reflect on this is that CTG is always a tool with a 30% positive predictive value. Like it's not a very high positive predictive value tool. Like what I mean to say is that if the CTG is abnormal, then there is 100% chance that if we deliver, the baby is also going to be abnormal. So it's not like that. But the thing is, which I want to interpret, and as Mr. Naguib said, if we look into complaints into GMC, 90% of these complaints related to childbirth are actually, oops, sorry, sorry for that, actually related that why wasn't this baby delivered earlier? Now, given this background with this CTG, given this background with this CTG, I don't find it wrong for an obstetrician to deliver this baby earlier if they feel that there is a particular reason to do that. Because as Mr. Naguib said, like, okay, yeah, the only reason this baby was left unhurt was despite having the storm, the baby never had any hypoxic events except the second stage. And I think
So
that's
we
what
were
saved.
very lucky.
And I think that's where they were lucky, and that's where the baby was saved. But if you look into that, if this was a typical choreo, which what Jane mentioned, that the CRP is not in like increased because there is a lag going on, and later on we do a blood test and we find the CRP it's in the range of hundreds or 200s. If the baby would have received any neurological damage or maybe a prolonged NICU stay and ultimately some unfortunate events, retrospective diagnosis would always have come. Why haven't we delivered this baby earlier?
Exactly. Exactly. I agree.
Agree.
Because
I
yeah,
agree. Yeah.
Yeah.
Like that's how I feel about this.
And not only Neil, let me tell you, I am now. They keep sending me CTGs similar to what we saw now. 15 years down the line, not 10, not immediately, and the upgards were fine and the gases were fine. And they claim they have not got into A level and they didn't get 3 stars. And they are still having issues, and even the trusts now are doing resolution with them, looking at the CTG that it is like that, and they say yes, and they pay under the NHS resolution. So I'm telling, the problem is, again, as Maya said, it is fantastic, and 2 cases reported and so on. The guy who is going to comment on it in the GMC is somebody who, as I say, most of the clinical experts at the moment that I have encountered personally have been out of practice. And I know that some people, even in nearby hospitals, they haven't been doing obstetrics at all. They are the experts for GMC and so on. So you are absolutely right. Delivering wouldn't have been criticized. It is fantastic to what I think Maya wants us to do today is think outside the box and think and think and think, and not dissociate the CTG from the whole clinical scenario, which is absolutely fantastic idea, to try to brainstorm and not isolate the CTG and say, oh, pathological deliver. No, thinking as well. So that, which is absolutely right.
But Mr. Naguib, do we all agree that that baby must have been delivered earlier? Like I can feel that we are all agreeing to the same thing, that any one of us in the same situation would have delivered that baby earlier.
I would have, like they said before, I would, the second the CRP is negative, like was low, I would have argued with the anesthetic doctor, put a spinal in her and delivered the baby with a section. And then
the second point, when we have an undiagnosed or undiagnosed tachycardia, we always do like a CTG, the ECG first, and then FBC and thyroid at that point, if we don't understand the reason for the tachycardia. But will that be in the like a local guidelines or anything for the reasons for tachycardia?
We wouldn't usually do that in the presence of pyrexia. We would normally all think of tachycardia related to pyrexia. So I certainly wouldn't have sent TFTs in a labouring woman with pyrexia and tachycardia. I might have been a woman turning up to clinic with an 140 well, but I wouldn't have thought to send it.
Even with
agree
when the
with
temperature
Natasha.
got down.
Not in labor, Omar. We are maybe we are making ourselves over smart now, but in labor we wouldn't have done TFT. Again, if you are doing a risk assessment and risk management in any hospital, and this is, I hope, all of you, when you become the risk leads in your hospitals, think of the case in prospect, not in retrospect, because we are always becoming smart retrospectively. So I wouldn't, as Natasha said, done TFT for her in labor.
Omar, one thing I want to mention, as Maya said, is that there are only 2 cases reported. So this is an extremely rare situation. Like, I'm thanking Maya because she took up this rare case, and it's really a eye opener for all of us and thinking out of the box. But like, if I'm a registrar at night and I'm encountering this case, the first thing which I will think is about safety of the baby and safety of the mother. If I'm not sure about the diagnosis, I'll definitely give the benefit of doubt to the baby itself, not keeping it to the heroics for me. Because at the end, if the baby delivers okay and I diagnose a thyroid storm, definitely I'm going to get quite a lot of praise from the department. But like, at the same time, if this is not a thyroid storm, this is a definite choreo with a lag phase, and the baby is delivered brain damage, then definitely that baby is scarred for life. Like, definitely, if I compare between my heroics and a baby being scarred for life, I'll definitely choose a safe delivery for the baby, and I'll deliver the baby quickly. It doesn't matter that if I face criticism later on and people tell me that, okay, on retrospect, if you would have allowed the delivery, the baby would have delivered normal. Well, that's absolutely fine. But at that point of time, with my limited knowledge and my limited resources, I will do what is best for the mother and the baby, isn't it?
Very sensible. Very, very sensible. Yeah.
Yeah, and I want to add that in the COVID time, all of us encountered similar situation, and the baby wasn't like hypoxic, but we were pushed and urged and like pleaded by the anesthetic team and by the medical team to deliver in order for the mother to live, because the sepsis was about to kill her. So again, the heroics to do, I agree, it would have also killed the mother herself. Yeah, because we do it in prospect. Yes.
Hopefully we'll have some cases of COVID cytokine storms also to look into and see how they can affect the traces and how we can change management according to that. So also hopefully, Mr. Naguib, if you've got any, or Kara, please, that would be very exciting and interesting as well.
Yeah. If I don't
Absolutely.
have a carry on, Mr. Naguib. Yeah.
No, carry on, Neil, my friend.
Yeah, I'm wondering, like, if I don't have a diagnosis or I'm not sure about what's going on, the first thing to prioritize should be the safety of the mother and the baby, isn't it? Rather than waiting on and keeping on and later on, like, delivering a normal baby and like expecting the heroics. I wouldn't prefer that way, definitely, because if I'm wrong, this baby is scarred and this family is gone totally for the entire next life.
Agree.
Yeah, no, it's fun. But thank you so much, Maya, for this.
You're welcome. Thank you all for coming. I'm very impressed with the attendance today. That was awesome. Thank you so much. And hopefully we'll keep on having this regular meeting with such amazing attendance, and we'll have more cases. Thank you, everyone.
Thanks, Maya.
Thank you, Maya.
All right. Have a good night.
Thank you, Maya. Thank you.
Thank you so much, Maya. Thank you.
Thank you. Bye-bye. Bye-bye.